And I'll just start with, some facts to kind of ground the conversation we'll have this afternoon. We know that diabetes outcomes in the US remain suboptimal despite advances in therapy and technology. Multiple studies have shown that most of the people with diabetes are not meeting the American Diabetes Association standards for glycemic outcomes. And there's persistent disparities by age, by race and ethnicity, and by insurance types. The use of diabetes technology is still lowest amongst Hispanic, non-Hispanic, Black, and Medicaid-insured youth. There are ways that T1D Exchange, we're trying, but there's still more. We developed the equity framework that sites can use when you're thinking about the QI project. So far, we've had more than 40 equity-related manuscripts that have been published. We also have the HEAL committee that helps us and advises us on equity-related work, but we know there's more, and that's why this conversation is important. My name is Odugbesan. I'm the Associate Director for QI and Health Equity. And today, with me on the stage, is 4 amazing, wonderful physicians, and I'll let them introduce themselves. So you tell us your name, your institution, and probably share an experience or a time that deepened your interest or your passion in health equity.
All right. Hi, everyone. I'm Janice Wong. I'm pediatric endocrinology at UC San Francisco. I was thinking about this question and one example of many moments where I think this stood out. So this was not really in the context of QI, but this was in context of a clinical study where we had given access to AID systems to publicly insured patients early in diagnosis, and it was in a focus group situation. So we had the opportunity to actually talk to the families a little bit more, and one of the mothers of one of the teens, I think she was a teen in the study, said, the research coordinator kept asking me about being in this study, and I kept saying I'm too overwhelmed, but then the teen had shared with the mom, why did you tell me this earlier? Because yes, I want to do this. And so it just illustrated for me, two things. One, talking to your patients about what their barriers are, and 2, really being persistent, I guess, and also the different perspectives of caregivers and their children. And so there are stories like that kind of inspire me to kind of keep going with this work. Thanks.
Hi, good afternoon, everybody. My name is Nana Hawa Yaya Jones. I'm a pediatric endocrinologist at Cincinnati Children's Hospital Medical Center in Ohio. And it's not a moment that keeps me doing this work, it's actually lives. And so paying tribute to Sonia, Thin, Ella, Matthew, Mark, Cameron, Brandon, Deasia, Madison, Jamil, Bri, and Rashid. These are all warriors with type 1 diabetes who lost their battle, so I have to sit here to continue the fight.
Hi, I'm Shida Majidi. I'm the Director of Diabetes Services at Children's National Hospital, and my path to making health equity kind of the forefront of my mind and my team's mind starts way earlier. So it actually starts when I was in middle school, being the daughter of immigrants, and throughout my childhood, sometimes we had more money and sometimes we had less money. And when we had less money, there was a clinic that we would go to that had a sliding scale that would provide us care, and that it would ensure that I was able to get the care that I need. And so that was one of the first times that I saw how important it is from the medical aspect to be able to have ways to make sure that we're treating everybody and giving everybody the care that they need. And so I'm just very thankful to be at Children's National Hospital where, just talking about our type 1 diabetes population, we have over 50% of our population that is not white, which is, a bit unusual in this setting where, you know, it's changing, but is still a primarily Caucasian disease. So, you know, me and my team think of it more as like our responsibility to make sure that we're thinking about health equity and the gaps of care, because this is the population that we serve.
Hi, I'm Janine Sanchez, pediatric endocrinology from the University of Miami. And I think one of my aha moments was realizing that for a lot of my Black and Hispanic patients that were using technology, they were using still older technology. So they were last to go on a hybrid pump, last to go to the latest Dexcom. Kind of realizing that, yeah, eventually they were catching up with this, but it was taking longer than it was for other people, and why are they having to delay in this care when we know these things work, and why is it taking longer for them to get it, longer for their A1Cs to improve?
Thank you, Dr. Sanchez, and I'll start with you. From your perspective, what are the most pressing gaps in care that you see in your institution? And do you think this is changing over the years? Is it widening? Are the gaps widening or narrowing?
So again, I think technology is the biggest gap. That is taking longer for some patients to be able to get on the latest technology, and some of it might have been from us, and so we started now making changes in our flow sheet. We have a question that says, why are they not on a sensor, why are you not on a pump? So that at every visit, that question is brought up if they're not using that technology, so that everyone is aware, whether it's, you know, a CD or the physician or a medical student is aware to ask these questions and to, you know, advance this for all the patients.
And Nana, from your perspective, what, you know, from Cincinnati, what are the most pressing gaps?
Yeah, I would agree with Dr. Sanchez that it's inequitable access to diabetes technology. I would also add fragmented care, and that actually came up recently on my week on service. I was on about 2 weeks ago, and I admitted 2 patients under the age of 12 who were on their 11th and 12th DKA. And when I pulled up their chart to kind of look back, I had seen that each of them had seen 3 different providers in the previous year, despite the fact that one of them was on a consistent care team. And so that fragmentation of care, I think, also kind of added to the disparity for those 2 patients that I saw. So that's another kind of piece. And then I also think like undetected and unmeasured and undertreated psychosocial barriers, including social determinants of health. I don't know that every institution is looking at social needs screening consistently across all care populations. And so if you have inequities in housing, you have economic disparities, you have low health literacy, you have no means for transportation. You know, I was just on another call with a CHW, and I have a mom with a type 1 diabetes patient who's unhoused, right? And it's like, oh, we're trying to find her a shelter. Like those type of things definitely are leading to a lot of the inequities that we're seeing in our type 1 diabetes population.
Thanks, Nana. Specifically for diabetes technology, are there specific inequities that you see with access to diabetes technology?
Absolutely. I think it affects those marginalized populations the most, so those who are publicly insured. I think there are still some states where you have to do prior authorizations for CGMs. Fortunately, in the state of Ohio, we don't have to do prior authorizations, but still getting access to that technology from a DME standpoint. So, you know, you prescribe it, you send it to the pharmacy, the family actually wants it, but then the DME says they need to get in touch with the patient in order to verify the address, and then 3 months later, they're still not on their diabetes technology, despite the fact that all parties wanted them to be on it. I also think that some of the inequities include access to phones. So I've heard here that you guys have had some donation programs, and so we've created a phone donation programs, but we have a lot of our marginalized community that do not have access to the iOS or Android devices that are compatible with diabetes devices. Even recently, I came across, you know, diabetes stigmas, and another huge one. And so we actually, I think, had a clinical patient in a trial for inhaled insulin, and they got in trouble at school because they thought they were vaping. So some of the lack of knowledge, you know, that continues to exist in the community about how to care for diabetes also creates inequities and diabetes stigma.
Thank you, Nana. Shida, what role do social determinants of health screening and referral play in your clinic?
So we actually started with Lydia Hawley as a co-lead, implementing social determinants of health screening at new onset. And so this is something where, I mean, we all know that there are barriers that exist to families being able to do, you know, the optimal level of care. And I think one of the big things is that it's not because they don't want to. I think oftentimes the thought is, you know, they're just not wanting to do this, or like mom's not doing this, where there's actually barriers. And so we implemented the screening program to happen at new onset with our social workers asking the questions so that we can see from the beginning what are the barriers, and then we can follow up with resources. We have our community health worker reaching out about a week after to see if they were able to access the resources. And we still have a ways to go in terms of trying to have more, you know, opportunities and more resources that we can connect them with, but it's definitely a start, and starting early is just really important so that we can, from the beginning, kind of see what those barriers are and try to help them through it.
Thank you. Janice, can you also give us your perspective from your clinic?
Yeah, so we've been fortunate at our medical center that on the inpatient side, there was an effort in pediatrics to do social drivers of health screening for all inpatients to start. So that was happening, which meant that a lot of our new onsets and anyone else who hospitalized was getting screened. But we also, on the ambulatory setting, we're one of the first, I think, ambulatory clinics in pediatrics, and maybe even actually the health center, even including the adult side, that implemented screening in our ambulatory clinics, which we started just in person at our main clinics that we're slowly expanding to virtual visits, because at our center we still see a large percentage of our patients by telehealth. And so we've been really, I guess, happy that we've been able to do that. So we're just doing paper screening. We're now moving towards welcome tablets. I was talking to some others about that, and doing electronic screening as well, and screening by my chart. And I think, you know, the question is like how important it is. When I looked at the numbers, I was actually, I was surprised by the percentage that were actually screening positive. So we're screening for food insecurity and transportation insecurity. And I think our numbers they ranged from 20 to 30% who identified as being food insecure, and about 10 to 15% with transportation insecurity. But then when I talked to my team, they're like, yeah, that's about right. And it just, you know, the fact that we could identify those patients routinely, and then first we've been referring them to our social workers. We now have, like, through our institution, some more electronic resources that are integrated with EMR. Find Help is what we're using. And it's been helpful to identify. We still have a long way to go. There's still a lot of those who, I think we need to follow up on those. It's like, okay, we can refer to resources, but, you know, I think knowing how patients are actually utilizing those resources is probably where we need to go next.
Thank you. We've talked a lot about real-world data insights. Shida, I would like to know, how are you using real-world data insights to identify gaps in your system? And then, are there any challenges in turning this data insights into actions?
Yeah, so I can give a couple of examples. I mean, we use the Type 1 Diabetes Exchange dashboard. It helps us get like a 10,000-foot like view of what is happening with our patients and in our clinic. And then we can take that data and go into our own EHR system and be able to then extract more detailed data and set up ways to be able to follow that data. So a couple of examples that we have is one, Amanda Perkins, who's one of our nurse practitioners, is leading our technology QI group, which is working on trying to increase or decrease time to AID initiation, and so we can use the data that we're able to extract and have follow-up to see how are things going, and also really to assess, are we ensuring that we're being equitable? Because it's always so important to have that from the outset, to be able to say, if we're making a change, if we're doing an initiative, that we're doing that and monitoring that so that we can make any adjustments that we see. The other is similarly using kind of data infrastructure. We have a clinic that Jody Grunman and Amanda Perkins lead, the Blossom Clinic, that really focuses on providing multidisciplinary care to our patients who have the most barriers, to be able to give them great wraparound care, and being able to use that data to be able to assess whether the outcomes that we want and need are happening, and if not, to be able to make those changes in real time. I would say that a couple of the things that's tricky in data will not be surprising is you need somebody who is able to get that data. So we're very thankful to have somebody like Lydia, who is our clinical care coordinator, who's kind of our data extraordinaire, mostly self-taught, who is able to get that data. But you're always, in the sense, at the mercy of the data that you're getting. So our EHR system, for example, there's 5 different ways you get A1C, so you still have to clean up that A1C list to get it. So it's still time consuming to get some of that granular data that you need, and that's where we need to continue to make efforts.
Thank you. Dr. Sanchez, what are some barriers, what are some challenges for your center? What are some challenges that it's standing in the way to make data insight actionable?
So a lot of it's just making sure that the data that's coming into the Type 1 Diabetes Exchange is accurate data. We've seen some gaps there. The numbers are not matching the numbers that we have, so making sure that we're getting that data, and then being able to use that data. Sometimes we can see where our gaps are, what are we missing, what do we need to do that we're not doing, but then being able to go to administration and say, hey, this is where we're behind everybody else, and trying to use that data to convince them, we need another, psychologist or a CDS or whatever it is that we are behind on, or we're not doing enough of these screenings, and to be able to use that data to convince them that we need to do this.
All right, thank you. We've talked a lot about some challenges and the issues, but I just want us to spend some time now just, thinking through ways that we can provide solutions, kind of some ways that we can, improve access to care. So, Nana, how do you approach a patient that meets all the criteria for diabetes technology but still facing barriers? What are some ways that you've helped patients like that at Cincinnati?
So I think one of the first things is to identify the patient, right? So we need a system in which to identify which patients are not on technology, and identify those early, even prior to coming to clinic, so that at the clinic time there's space and energy to address those technology barriers. And then even creating a list of what are those technology barriers. So is it financial? Is it technical literacy? Is it language? Is it psychosocial? Is it diabetes distress? Is it caregiver health? A list of those kind of barriers to technology intervention. And then after that, what are the potential solutions? So if it's depression, if it's diabetes distress, if it's diabetes stigma, then what are your psychological resources to address those barriers? If it's financial, what opportunities does your clinic have or your institution have to address those financial barriers? If it's literacy, in what other ways is your literature or your education being taught? Are you a visual learner? Are you a literal learner? Do you need demonstration? So a lot of times in diabetes, we use this very strict curriculum for diabetes education, but there's not a one-size-fits-all. And so we need to be very flexible in the way that we deliver diabetes technology education to different families. Shared decision-making, I should have brought the model that we had at Cincinnati Children's Hospital, but we have almost like a comparative chart. It's a laminated sheet that has all the different ways that you can manage your diabetes: basal bolus with meter, basal bolus with a smart pen, basal bolus with a CGM, pump and CGM separately versus hybrid closed-loop systems. And then we basically kind of list out the benefits of each, and have little icons next to it with talking about cost, visibility, alarms. So I kind of akin it to when you go to Best Buy if there still are Best Buys around, and you make a decision on what printer you want. You know, they give you the specs on each one and what each one can do. And so we have that shared decision making, and then we kind of, again, having that discussion with the families in real time. We've also created videos. So we have a CGM video that's available for you guys to view, but we're also creating an AID video. So we have those patients who were very resistant to technology who have now come on board and discussing their experiences. And there's no greater impact than hearing from your own peers who had the same fears, right, and the same barriers as you, how they overcame it and why they're using it. So we have that available to us as well. And then, of course, just education and support. I love one of my patients with the CGM video. It was like, why did you finally get in a CGM? Because Dr. Jones nagged me until I did. And I was like, if that's what it took, then that's fine. And now you can't take the CGM away from her. But I think that a lot of us, when families refuse or decline and they don't want it, we're afraid to bring it up again. But I think we have to, you know, again, using the language that we know to use to patient-centered care, we should bring it up again and consistently kind of address, because they change over time. The developmental stages, of course, in pediatrics also changes over time too.
Thank you, Nana. And I'm going to, still ask you another question. You talked about patient-centered care. Is there a way that you integrate patient voices into some of the work that you do?
Yes. What is it? Nothing for us without us, right? Is that yes? It's absolutely yes. Patient-centered interventions are very important, and so in any quality improvement project that we do, we try to have a patient voice. So we do have a patient advocacy group that one of our CDCES manager actually created, where we have a panel of patients in collaboration, and whenever we do a different intervention or have a different study or have a different quality improvement project, or we want to change something in clinic, we want at least some patient voice in there to make sure that we're doing the right thing at the instant, right? Or maybe things that we haven't thought about too. And then it's so important for advocacy, right, to have the patient voices. It's those with the lived experiences that have the greatest experience in helping us to realize what to do better, where we can change, and where those gaps are. So not only do we have that patient advocacy group, but we also a lot of times take our interventions to the patients. So for instance, the CGM and AID video we talked about, those are just patients. They're talking. So we brought them in and had our videographer and asked them questions, and they were able to answer them in real time so that we can show videos to the other patients as well. And then we have connection events that we have, like we had our annual zoo event at Cincinnati. We have the Cincinnati Zoo and Botanicals, which is one of the #1 zoos in the country. And there's an event called the Festival of the Lights where they put all the Christmas lights up. And a lot of marginalized families have never been able to experience it despite living in Cincinnati. And so we give them the opportunity to come to the Festival of the Lights on Cincinnati Children's Hospital dime, right? And we have these community engagements where they get to connect with each other, because otherwise a lot of families won't get a chance to meet each other. We also have our own internal Facebook page that's moderated by our team as well to help families connect.
Thank you so much, Nana. Dr. Sanchez, what's your team's approach to improving equity?
So we started out by doing some focus groups. So we had separate Black focus group and a Hispanic focus group. And we essentially went through the questions about why using technology, why you're not using technology. Do you like the way that we're teaching? Would you prefer inpatient? Would you prefer Zoom? What are the things that you think we need to do differently, and how we're approaching you, how we're approaching technology, how we're talking with your child, how we're talking with your families, and just get feedback from them on how is it better for us to deliver the education to them and to encourage them to advance with their diabetes care. And then we're able to use that information from our focus groups to then adjust how we're doing it, our education, and to kind of disseminate this against, for all the providers. So everybody's kind of aware of what the focus group is saying and how to make changes.
Thank you, Dr. Sanchez. Shida, can you tell us how your team is approaching improving health equity?
Yeah, so some of it I already discussed in terms of some of the other projects that we're doing. One of the, I would say, big ways that we're doing it is we're really focusing on food insecurity. And so when, during COVID, our dietitian, who's now our diabetes educator, Alex Richardson, was realizing that a lot of families were having food insecurity, and so started a pilot project to really see what what was actually happening in terms of, how many of our patients were having it. And at that time, it was about 2/3 of our population that was coming through our door had food insecurity. And she was like, we got to do something. And so this was before I came. It came right at the end of this, but started like a year-long process of getting everything set up and approved and through legal to actually have what's called a food pharmacy within our clinic. So we partner with capital area food banks, so partnerships with other people who have similar interests, who now provide us weekly groceries that we can provide shelf-stable food and then also fruits and vegetables to our families who come in. Right now, post-COVID, our rate is about 40-50%, so it's still a significantly high rate, but to be able to give them 3 days worth of groceries, it's something small, but still like significant, and we've served about more than 2,500 families to date, and so that's just one example of the things that we do, but working with other people in the community who have those similar interests.
Thank you. Jadis, can you share an example of a QI project that, maybe your team implemented that helped to address some care gaps, and what did you learn from this?
Yeah, so I think a couple of years ago, we were looking at some of our data on the differences between our publicly and privately insured patients and differences in glycemic outcomes, probably everything that you all have experienced. And really, we're trying to think about ways that we can reduce the gap in median A1C, or however you want to describe it, those with A1Cs above 9% or below 7%. And so there are 3 key drivers, which ended up being all 3 QI projects kind of nested in this larger. The first, as I talked about a little bit ago, was addressing social drivers of health and implementing screening. The second was what we've called Tequity, and I think we've talked about that here, but it's essentially what many of you are doing, is really improving technology access for publicly insured or any other under-resourced or marginalized populations. And so our CGM Access Project encompassed a lot of different interventions: CGM education direct to patients, implementing a CGM start at diagnosis, like many of you are doing on the inpatient side, and focusing both on new onset as well as those who were hospitalized with diabetes, but were not already using CGM, and focusing both on type 1 as well as type 2 diabetes. And the third is related to what I think some of the others have talked about, is really recognizing that culturally appropriate supportive care, culturally supportive care is important, whether that is coming from the clinic or from peers, and you heard a little bit of that here too. So we partnered with our local advocacy organization, Diabetes Youth Families, or DYF, in a mentoring program, and then separately are really thinking about ways to introduce the idea of technology and other aspects of management in a peer setting. So whether that's groups, shared appointments with those who are from similar communities or cultural backgrounds, are areas that we're moving towards.
Thank you. And I'll just still, while you have the mic, how can academic centers better train the next generation of physicians to use QI to improve outcomes for people with diabetes?
Yeah, I like this question because I'm also a program director for Peds Endo Fellows. So a couple of things. At my institution, what's nice just for not just our trainees, and many of your institutions are like this, we do have QI resources that are available. I have the luxury of working with our Department of Quality and having a coordinator from the Department of Quality who has training in QI tools, and together we're able to bring that to our clinic teams. And so for each of our QI projects, as many of you do, we create task forces, and those task forces, depending on interest in what the topic is, bring in many members of the team. And we use that as opportunity to talk about what QI tools are and what's a KDD and how should we approach this using PDSA cycles. So we've done that with our clinic teams. In addition to that, for our trainees and for our fellows, our GME actually offers a couple of opportunities. One is actually an incentive program program, which they call the Reflect program, where our fellows have the opportunity to work with the QI coach outside of our division and to create a SMART aim that they actually, if they achieve that aim, they actually get a cash incentive for doing that. And so many of our trainees have participated in that, and I, along with some of my colleague Angel Nip, who's here as well, have coached our trainees in doing that. And I think those are nice opportunities to involve the fellows. And as program director, I get to require that our fellows all participate. So that's another thing that you can do as well. And I am super proud of the projects that our fellows have done. Two of my former fellows are now like QI leaders who are in this room today. And so they go on to do amazing things. And so definitely I believe in the power of training the next generation in QI.
Thank you so much. Shira, do you want to take that question too?
Yeah, I mean, I echo everything that you said. You said it, amazingly. The one other thing that I would add is, the ACGME requires for endocrine fellows to complete a QI project, and I feel like there are some cases where it could just be like, oh, just do something that will fill it and we can just sign off. But to really be intentional about okay, let's learn about what quality improvement is. If there is something within your institution that provides that education that's unique, we have something called Quilt. Is there a way that we can integrate that as well? And then really just as the opportunities, come up and there is this requirement for, QI, to just say we can literally do anything that you have in terms of a question or anything that's part of diabetes care can be done through quality improvement. And so there are just so many options and just having those different ideas available. But I think really it's just being intentional with the fact that it's already a requirement, but actually making it something that they'll learn and they'll be able to grow from.
Thank you, Shira. Nana, how do you see AI, automation, predictive analysis changing the next phase of diabetes care?
So I said in a different life I'd be bioinformatics because of how AI is changing the next generation. So I think, we know this very well with our AID systems, right? So the automation is going to become more and more closed-looped and more hands-off. So I can see that our technology gap or tequity is going to worsen if we don't give everybody access to technology as the technology rapidly advances. So definitely automation in the diabetes technology space is accelerating at full speed. I think personalized glycemic forecasting to reduce crisis. So there are a lot of models now predicting diabetic ketoacidosis. And as we get into ketone monitoring too, I think AI will be a force in that area. And maybe we can reduce hospitalizations and the comorbid consequences of diabetic ketoacidosis by having those prediction models. I've seen a lot of dashboards being presented too. So if we can use those dashboards to predict who's going to have a hospitalization or who's going to have an undesired outcome, that would be another area. Psychosocial support in the AI system is also very important. I think we don't have enough psychologists, especially diabetes-specific psychologists, and so we can use automation and AI to detect diabetes distress, diabetes burnout, diabetes stigma, depression, and anxiety. I think that would be another area of opportunity where AI could be helpful in our patient population. And I think that we just all need to get on board with AI. I think we're all very resistant, but it's coming whether we like it or not. And so we need to be the ones in the room to inform the technology and make sure that it doesn't increase the gaps that we are already seeing in diabetes care.
Thank you so much, Nana. We're going to be wrapping up, but I just want to go around. What's one thing that you think T1D Exchange can do to support sites in addressing care gaps? Just one thing, and then we'll go around.
I think giving us the data on what other organizations are doing, that's what's been key for us, is to be able to see and, as they say, steal shamelessly. It's been wonderful for us. Our whole flow sheet, it was designed based on the Type 1 Diabetes Exchange, and be able to see the equity projects that other people are doing and being able to implement them ourselves.
I think just being really intentional whenever there is a new project or work group that's created to make sure that that there's equity in mind. Like, for instance, with everything that is increasing in terms of screening, in terms of, disease-modifying therapies, how do we start thinking about equity now so we're not looking back in, 5 years, 10 years, saying, look at these gaps?
I think the Type 1 Diabetes Exchange is already doing a remarkable job, but I think maybe we're on the forefront of trying to actually increase the number of centers that are engaged. And I think sometimes the cost to the center is higher than what they believe the benefit would be. So I think if we can figure out how to enroll more low resource centers into the Type 1 Diabetes Exchange, especially as we engage in Type 2 diabetes, I think that's one thing that the collaborative can really do to help improve equitable outcomes for everybody with diabetes.
Yeah, and along those lines, I was thinking about this as we're expanding to Type 2. There are many of the interventions, although not exactly the same, that are going to be relevant, especially if you're talking about equity and marginalized populations that are going to be similar in Type 2 and Type 1. And so I think encouraging the participation of Type 2 in our work is important, along with, I think, just in general, continuing to facilitate the sharing of tools. And I know there's a lot of talk about that all the time, but are there ways that we can actually, and I know there are limitations in what our EHR systems allow us to do and all of these things, but how we get so many good ideas when we come to learning sessions or we go to the meetings, but it's like, okay, well, I am inspired, but now what? And so how can we actually facilitate better sharing and collaboration in between the times where we're in meetings together and see each other? And I would love to see that improve.
Thank you all so much. I think we have time for some questions and answers. Some questions.
Hi, I'm Stephanie Crossan from University of California, Davis. Thank you all for the great thoughts that you shared and the work that you're doing. I'm going to throw out there something I've been wrestling with, and I don't know if anyone has answers, but when we think about technology equity, it's not just getting them access initially, right? It's staying on it. It's getting those supplies every month. It's navigating the system. And so many of our families who are struggling with other challenges, that's where they fall down, right? And even in our system, it shows they're on pumps. They're not getting their pump supplies every month. They're not seeing that benefit. And I think that our teams are all maxed out trying to help people and trying to fill that gap, navigating between the DME supplier, the pharmacy, the insurance company, right? And the families can't do it, they're maxed out. How do we pull in other players? How do we change mandates or incentives so that the tech companies need to do some of this? The DME suppliers have some skin in the game, because it feels like we're just running around with families in circles, and it doesn't feel like these other players are really contributing in the ways we'd like them to.
So thanks, Stephanie. I think you make an excellent point. When I think about things, I think of patient-centered, community-centered, but I also think about systematics, right? And the systematic ways in which we're actually increasing inequities, especially with technology. So I believe that we do need to figure out how to do this top-down. So there are, CMIS, right? As they make their rules and regulations, we need to inform those. NCQA, who does the quality metrics for the hospitals, they're beginning to change some of the mandates around what is quality in diabetes. Insurance companies as well, and then we need to continue to push our technology partners also to be helping us to do this work. So there is work in this space, but you're right. It's probably they're not as responsible for it as we seem to be, right? And so I think I would probably throw that question back out to the audience, like, who are the players who are at the higher level systems that can help inform some of these changes, right? The DMA process is ridiculous. Somebody needs to go in there and turn it upside down and change it, right? And the same way with the tech companies and the prices of their technology, like, how can we make this more affordable? And it could be across states, so it doesn't make sense that in literally across the bridge from here to there, it's Ohio and Kentucky, and I can get a CGM for my patient if they are on this side of the river, but can't get a CGM for that patient if they're on that side of the river. So, right? So what are some of these kind of state by state federal mandates that we need to help change to improve equity? And so I throw it back to you guys if you have stakeholders that you know of, people who you can talk to try to make these changes at the top level.
Hey, Mary Lauren Scott from UAB and Children's Hospital in Birmingham. How do you reconcile past experiences with providers who have shut them down about a pump, or part of me thinks there are some potential cultural experiences that are anti-device for some of my patients, whether it's, who they see at school, who their family members are, or don't see at school, right, wearing devices, because I feel like there's a higher degree of body image issues in some of my minority race teens, just because maybe they're not represented in the media or in their world as much. So how do you reconcile those? I've had good experience with some of my patients in my high-risk clinic that does have a peer support option, because they are able to see each other, and so some of the kids we've successfully transitioned to devices are able to then brag about it to their peers, but the group model is hard to do in larger settings, I think, but just ideas.
So for us, we hired, we have numerous Hispanic providers, so they're able to help encourage, so even if the physician's not Hispanic, that the nurse may be, or the MA. And then we also, we have a large Haitian population, and we didn't have a Haitian provider, but we were able to hire a college pre-med student who's Haitian. And I think this can work with other ethnic groups as well, where they can see him and he can talk about these things and speak in Creole to the parents and convince them. And so you have somebody of a similar group, and that made a big difference. And honestly, the Barbie doll has made a difference. We gave a Barbie doll to a little girl who said she's on one of the Caribbean islands, that she's the only child on her island with diabetes, and she didn't want to talk to anybody else about it. And having this doll that has a pump and a sensor, she said, now I can take this to school and I'm willing to talk about it with everybody else.
I'll just add really quickly, because I know we don't have a lot of time. So yes, peer, I would say peers is a huge one, but yes, not everyone can do a peer support model. So I'm a diabetes camps. I mean, honestly, I see so many things. I mean, honestly, I have patients who have not been on technology for a while, and then, well, I met this other person who's on a pump, and I think it's cool, or on a CGM or whatever. And so being creative with, and again, the theme is seeing somebody else who looks like you, who is using that from a child's perspective, and then from the parent's perspective, somehow getting them to connect with, even if it's one other family where they've had that experience where they can share whatever their concerns were, I think has been really, really powerful, I think, with some of our patients.
I think you're already doing the biggest step, I feel like, which is asking them and figuring out what the reason is. Because if you just say, are you interested, and they say no, and you're not talking or exploring why, then you're not going to get that maybe it is for a cultural reason that you can maybe then pursue. And sometimes working with their community leaders can also be something that can be helpful. And one of the other things I just thought of is, there may be an opportunity through videos like Nana you have, where they're seeing themselves on the screen talking about CGM use, talking about pump use. That might be helpful as well.
I wanted to go back to your comments about what I call diabetes supply distress, the difficulty to obtain and maintain access to essential diabetes supplies. And I think the biggest problem is it's not something that is measured. You feel that it's a problem because you spend a lot of time trying to solve this, but it's hard to say how often it happens. So we've been trying to measure this at the University of Cincinnati, and we've done surveys through the T1D exchange. And in the T1D exchange, 42% of people who responded said that they had had an interruption in CGM access in the last year. 25% said they had an interruption in pump supply access, and 12% said they were unable to get insulin at some point in the last year. And these are pretty motivated people who are part of a registry. We've added it as a question for the pre-visit questionnaires. How often have you not had access to a prescribed diabetes supply? And so far we're getting, people are saying 50% who are prescribed a CGM have had an interruption in the last 3 months, and the average duration of interruption was 9 days. So I think we need to start looking at these really important questions, measuring them, because once you have that data, it becomes clear where the problems are. We've also found in our study that using 90-day supplies significantly reduced the number of interruptions over a year versus 30-day supplies. You know, I think the deeper you look, the more you see, and the more opportunities you see to help.
Thank you so much. The panelists will be around, so if you have more questions, feel free to, reach out to them. Thank you so much.